Okay. Well, hi, everyone. So nice to have you here with us, and greetings to those in the, wherever we are up there in the sky, who have zoomed in to join us today. I hear we have several hundred. So thank you all for being here physically, but thank you also for joining us virtually, all the others. My name is Barbara Bass, and I happen to be the Dean of the School of Medicine and Health Sciences here at George Washington University, and the VP for Health Affairs here at the university as well. I also have the great privilege of being the CEO of our faculty practice group known as the GW Medical Faculty Associates. And when we bundle up those entities of our school and our faculty practice, we are really what we call GW Medicine. And we are one of the, and with that, we embody and embrace in our clinical practices those core missions of education, of research, of advancing our fields, of serving our communities broadly, and of course, that very critically important mission of patient care of the highest quality that we can deliver in an informed way by science and good practice. We happen to be this year, this is 2024 as we all know, well, it just so happens that our medical school, the GW School of Medicine, now known as the GW School of Medicine and Health Sciences, was actually founded 200 years ago. So we're celebrating our bicentennial year this year. That makes us the 11th oldest medical school in the nation, which we are very proud of, the oldest here in the nation's capital, which is rich with fine medical schools, I might add. We were founded 3 years after the university was founded, the George Washington University, which many of you, if you're any local history buffs, know was founded by an act of Congress, awarded a charter from Congress in 1821. It took a few years to get the medical school part going up in 2024, but here we are, and we're really celebrating this year with a series of symposia, series of outreach to our community, some focused on our community and our patient cohorts, others focused more on the scientific world to where we allow our researchers to shine and collaborate with their national partners, others more in the educational domain, targeting some special things that we do in education. In our many programs, besides the MD program, we have a physical therapy program, a PA program, occupational therapy, and of course, a PhD program that really does some fabulous discovery science, which we then as clinicians translate into the care we provide here to our community. So I'm glad to have you here to join us today for this special, I guess this is our second or third of these, and this one we're going to focus on brain health. And we do want to focus on health, not so much disease, but more on health and the things that we can do to keep our brains healthy, particularly as we age. I know my brain's not quite what it was maybe 40 years ago or 50 years ago when I started in this business, but I'm doing the best I can, and I hope we all do the same. And we all do our best to try to keep our brains healthy. It's also an area we want to focus on today because it is one of those areas here at GW where we have really spectacular and deep expertise, both on the fundamental discovery science side and particularly on the clinical trial and advancing science side, as well as on our clinical enterprise. And you're going to hear today from 5 of our noted clinician scientists and practitioners in the area of neurology, behavioral health, geriatric health, and as you'll see as we go through this, the functioning of our brains really can't be separated from much else in our bodies, but really relies on that wellness that comes across all of our healthcare domains in our bodies. So we're going to talk to you today about our special areas in stroke, as well as our dementia clinic. We have a lot of things we're going to hear about today. But first I'm going to introduce our very distinguished speakers who are here with today. Just immediate here to my left is Dr. Mohammed Kubaisi. He's currently the interim chair of our Department of Neurology and Rehabilitation Medicine. He's also a professor of neurology and rehabilitation medicine and directs our epilepsy center here at GW. He is an internationally acclaimed investigator and clinical trialist in the field of epileptic disorders. So thank you for joining us, Dr. Kubaisi. Next to Dr. Kubasi is Dr. Christina Prather, who is an associate professor of medicine, internal medicine, and she also serves as the director of our geriatrics and palliative medicine program, and she co-directs our memory evaluation and treatment clinic, hence our brain interest today, and a really noted educator and great servant to our community as she applies her deep clinical knowledge in these areas. Next to Dr. Prather is Dr. Nick Puente, who is a psychologist. He serves as the chief psychologist in the Department of Psychiatry and Behavioral Medicine here at GW. In his practice, he performs what are known as neuropsychological evaluations of patients with psychiatric and neurologic disorders, definitely interwoven areas at times. And he does this by performing cognitive, i.e. thinking assessments, behavioral assessments, and emotional functioning that can be helpful in diagnosing and treating patients to optimize their ability to function at their highest level. Sitting next to Dr. Puente is Dr. Stephanie Kelb, who serves as an assistant professor of psychiatry and behavioral medicine. Dr. Kelb has expertise in providing evidence-based psychotherapy and conducting comprehensive neuropsychological evaluations in patients who have a wide range of psychiatric and medical conditions. We are all woven together. We were just backstage talking about it's hard to pull out one organ from another. We are definitely organisms with so many inextricably interwoven parts. She has particular interest in working with individuals who have neurological illnesses, including dementia and neurodegenerative disease. Last sitting over there is my colleague, Dr. Henry Kaminsky, who is a professor of neurology and rehabilitation medicine. He is an internationally recognized clinician scientist and authority in the treatment of patients with myasthenia gravis. It's a chronic autoimmune disorder, a neuromuscular disorder, we say, characterized by varying degrees of weakness and skeletal, i.e. voluntary, muscles of the body. He is a remarkable clinician scientist whose laboratory has been funded for 30 years, over 30 years, continuously by the NIH, and actually as an internationally recognized scholar leads the NIH's program on rare clinical network trials on rare diseases, a really important component of healthcare that often don't get the attention they need. So thank you, Dr. Kaminsky, for being here to help us today and provide your insights on this. So why don't we get started? And I guess we could start by, why don't we start with you, Dr. Kubasi, since you're our current lead authority here in our Department of Neurology. And I think what people often wonder about when they say, well, my brain's healthy, my brain's not healthy, how do we describe the state of a healthy brain? And what are the common things that, once we get that understanding, that we can all do to try and optimize that healthy state?
Thank you, Dean Baz. That's a great question. The brain is what makes it possible for us to understand language and speak and sense the environment through our senses and sense the internal environment, of the body. It's crucial for cognition and emotional processing. I will focus on a couple of specific things. Cognitive health is one important and fundamental characteristic of a healthy brain.
And that's how we think, right?
Exactly.
Cognitive is how we think and are
Totally,
rational.
yeah, exactly. So cognition refers to thinking, having good memory, processing information, having proper decision making, and it's essential for how we navigate life every day, including imagination, synthesis of ideas, and so forth. And the other thing is emotional processing. So the healthy brain processes the emotions in such a way to decrease stress. One important aspect of that is to be aware of one's emotions and to express them, to solve interpersonal problems, to solve problems in such a way that it decreases the level of stress and increases the level of psychological well-being. Another important feature of a healthy brain is what we call neuroplasticity, which is the ability of the brain to adapt and to learn. So it's called neuroplasticity, which means, in a way, malleability and formation of new connections within the brain cells, which is indispensable for learning and for adaptation to various stimuli, whether health-related stimuli or world-related stimuli. And it's also important, plasticity is also important to recovery from injury. Whenever a brain area that is specialized in a specific function is injured, the surrounding areas of the brain take over that function, and that's part of what we call neuroplasticity. And in addition to that, there is what we experience all the time, is the awareness of the whole world through the senses, vision, hearing, and taste and smell and touch, and also movement. These are all functions of a healthy brain. When it comes to the second part of your question about what can we do to maintain a healthy brain, there is a lot of research about the importance of exercise. Exercise, whether it's aerobic or weightlifting, any exercise is very good because increased blood flow to the brain enhances the blood flow, and it enhances something called neurogenesis, which is formation of new cells. So if you read a neuroscience book from, I don't know, maybe the mid-last century, it was a dogma that brain cells do not regenerate. But now we know better. We know that a lot of brain cells, can regenerate, and there are numerous experiments in humans and in animals that have shown that exercise can cause regeneration of the neurons, which are the brain cells that are important for memory. So this can improve what we call the cognitive reserve of the individual. So exercise is one very important area. Diet is another crucial area. Diets that are like rich in saturated fat are not good for you, or a lot of sugar, so we should always try to eat fruits and vegetables and healthy fats, like for example, omega-3 fatty acids, which is in fish, and whole grains. That's also very important for the blood vessels and the health of the brain.
Sounds like what we'd call the Mediterranean diet.
Right, exactly.
Okay.
And actually, you're totally right, because there are studies that have shown that the Mediterranean diet decreases the risks of stroke and of Alzheimer's disease. And the other thing is good sleep. One should try to guarantee 7 to 9 hours of sleep. And again, some people may think they sleep 8 hours, but they are in the morning tired and unrefreshed, and they should undergo like a sleep study to assess the health of their sleep, because poor sleep can lead to poor brain health as well as other issues such as weight gain and high blood pressure and cardiovascular disease. But then also for a healthy brain, I'm gonna go over a number of other areas that are crucial. Social interaction is very important. There are many studies that have shown that people who don't have much social interaction, not only they get more prone for depression, but also to a lot of health-related diseases, including dementias and even cardiovascular disease. And another thing is brain stimulation. Just like exercise is crucial for the muscles, brain stimulation is the exercise of the brain cells. So if one embarks on lifelong learning of new languages, of reading books, of doing some digital exercises, for the brain, for the memory, and what have you, it's very helpful, because it again increases what we call the cognitive reserve, so that if there is some future insults, the brain will maintain its function. All of this is crucial, starting from food to sleep to exercise, social interactions. There's also stress reduction measures such as yoga and Tai Chi and meditation. There are lots of studies that have proven that these are very good for the brain. But very important, and I will close with this, it is to check with your physicians on a regular basis. Your doctors will be able to tell whether your weight is good or not, will be able to tell whether your blood pressure is good or not, your diabetes, your cholesterol, will advise regarding exercise and everything. So regular checkup will identify early on issues that are reversible and that will maintain your overall health and your brain health.
Yeah, very good. Thank you very much. Maybe that's why I do Wordle every day, to stimulate my brain, right? Does that work? Does that help?
That's perfect.
Okay, there we go. All right. All right. Well, we've heard a lot about how to keep us well, but obviously there are some things that do come to us as disorders or as conditions and pain points for patients. And you lead one of our large premier departments, and Dr. Kaminsky was previously our chair of this department, and built much of the department as well before he decided to go back and be a scientist, and more of a complete full-time scientist than a clinician, but he still sees patients too. So I guess just in general, what's the scope of what falls into that bucket of neurologic disorders? So who do you see in your clinics, and what expertise do we have here at GW?
The scope of diseases that we see in the neurology clinic is broad. Obviously, some of the most common neurologic disorders include headaches, not only migraine, but several kinds of headaches that need appropriate diagnosis and treatment. The epilepsy is another common condition. Epilepsy affects about 3 million individuals in the United States. It's very common. And stroke is very common, one of the most common, Alzheimer's disease and the dementias in general. We see also diseases of the spine and the peripheral nerves, so not only the brain. So the specialty of neurology includes not only brain health, but also spinal cord and the peripheral nerves, which are the nerves that are outside of the spinal cord and the brain, and as well as diseases of the muscles. We see a lot of neuroinflammatory disorders like multiple sclerosis, very common. And in each of these conditions, there are like recent advances and recent medications that have changed the way we manage these disorders. There's also a whole specialty related to neurorehabilitation, which is after there is a brain insult such as a stroke, then the rehab specialist now they're using novel techniques, including digital techniques to help restore the function of individuals with stroke and with other neurologic disorders. This is very briefly the.
Yeah. Dr. Kaminsky, do you want to comment on sort of this notion of neurological immune interaction and how that has changed our therapies, our diagnostics, our other neurologic disorders?
Absolutely. So myasthenia gravis, the disease I study, is an autoimmune disease. So for some reason, there's a programming error in the immune system, and there's antibodies that form and start to attack the nerve-muscle communication point. It is a rare disease. Probably some of you, this is the first time you've heard about this. So why would the NIH spend a lot of money trying to understand this disease? Well, I think there's kind of two things, right? You take a deep dive on one condition, you tend to see insights into other conditions. Also, although there's only 200,000 patients in the country with myasthenia gravis, there's 17 million people with rare diseases. And so the kind of techniques you use to understand rare diseases are common. But getting back to Dean Bass's point, there's just an ever-increasing appreciation that the brain and the immune system almost are one organism, that they're using the same kind of transmitters. There's an interaction between our gut, which means what we eat, and the bacteria in our gut, and how the immune system reacts, and how that's transmitted into the brain. And then going to aging, which is common, fortunately, to most of us. And there are changes as we get older. There's more autoimmune diseases, and our laboratory here is discovering that there's particular mechanisms that affect older individuals that induce autoimmune system problems. And so we hope what we are discovering here can expand out to other conditions. And then that last piece of what Dr. Kabasi and actually Dean Bass also said about, what can we do to maintain a healthy brain? That's what we do in terms of when I hear a patient ask me, like, what can I do beyond the drugs that I give? Well, it's optimizing your diet. If you add too much salt to a population that have higher rates of autoimmune disease, you take immune cells, put them in a dish, add a little extra salt, they get activated. There's been a beautiful NIH study that shows that you can change the diet and look at various parameters after just 4 weeks, and there's significant improvement if you follow a vegetarian diet or a Mediterranean diet in the gut microbiome, the kind of metabolic parameters in the immune system. Also, so there's, as Dean Bass said, it's one organism. I can give a patient various medications, and there's new ones out there absolutely wonderful, but without that additional piece, I'm really not going to help that patient. And I just want to give also a shout out to my colleagues about that neuroimmune interaction. I take care of an immune system disease, but each one of them have been profoundly impactful on affecting these patients' brains, behaviors, and outlooks to optimize their overall health. And so I think that also, again, just speaks to the immune interaction. You know, I can tell you that our patients get double vision, get profoundly weak, and end up in the intensive care unit. That has profound effects on their psyche, and they're not going to get better unless I send them to one of my colleagues, because I can't do it.
Yeah, I wonder if you could just say, well, all of you maybe amplify a little bit on that notion of the team approach that we have at GW to treating these conditions, which range, you know, we could try to say it's your microbiome, or it's your immune system, or it's your whatever you want to say, but obviously this requires multidisciplinary teamwork. And how do you all work together? You must work together, huh? Frequently, I heard you backside.
I'm looking at Nick. So I got held up yesterday when I was rounding, so I didn't make our monthly interdisciplinary team meeting. So our memory clinic here is not just our geriatric team that cares for people in our clinics, but it extends to our speech and language pathologists who are part of the rehab program. It includes our social workers in all of our primary care practices, and also extending into our community partners with social work and navigation. And notably our neuropsychologists, who are just really phenomenal at understanding what's happening in people's brains when they come to us and say, I don't feel right, something's not working. And we're trying to determine, is this something that we can change or modify, or is this something that we have to figure out how to best live with? And so we get together every month and, with consent, talk about the people who we are privileged to take care of, and it helps us be better, to serve them better.
Yeah.
Yeah. And those are really nice, kind words. I think I'm going to bottle them and send them to my family so they can remember them. But we really enjoy working, you know, within the GW as a whole with our colleagues in neurology and the memory clinic. And I really feel like we can provide a home for people that need this interdisciplinary treatment. And sometimes it's hard for a physician in maybe an hour visit to figure out, are these memory problems normal or not normal? And that's what a lengthy, comprehensive exam can really help with. And then also help with the management of what we're all talking about, of these social factors and psychological factors that can implicate in not only your risk for developing things like dementia, but also just your general mental health of today.
Can I add to that? The other thing is, right, like what we know about the brain is constantly changing and growing thanks to the incredible science that's happening, and Drs. Kaminsky and Kaminsky alluded to that. But when we don't have 100% confidence in what's going on, we turn to each other and say, hey, this guy's not following the pattern that I think he should be following. What might I be missing? Because it's better for us to say something doesn't feel quite right and try to get the best answer we can, because it's really ultimately about helping that person, right? And we do that, and we tell the individual too, something doesn't feel quite right. Let's get to the bottom of it. I need to talk to my colleagues because they're really experts.
Yeah, no, that's really fabulous. And I think that is one of those special sauce things that you get at a top performing academic medical center. You do have this depth of knowledge, interaction, integration, and that is a real differentiator. And it also, it doesn't just help benefit that one patient, but it advances care globally, because we also share it and train it with our trainees as well. So thank you for making that so clear. Yes.
If you allow me. We are working now with, our department is working with Dr. Jeff Ackman, the chair of the Psychiatry Department, to start something called multidisciplinary clinic. So the vision is that in each clinic there will be a neurologist, a psychiatrist, and a therapist, and the patient will see these specialists sequentially. And then another patient will see them in different orders throughout the day, so that we guarantee for each patient 3 appointments in the same day, which has been shown in, in some other medical centers to improve outcomes significantly we will start with something called functional neurologic disorders, but this is extrapolatable into all neurologic disorders because almost all of them, they have psychiatric components.
Yeah, and that's sort of a new concept in neurologic disorders. Certainly in cancer, we've been doing that integrated care for some time, but it's really great to see it begin to be part of the backbone of the kind of care we can provide in a sophisticated environment. So let me move on to the thing I think that most of people are concerned about is aging and brain health. And I'm going to look to Dr. Kelb. So what happens when we get older? What happens to our brains? And what is a healthy brain supposed to look? We know it's going to be a little different, but how?
Yeah, well, I think, it's important to note that as we age, our brains change just like any other organ system in our body, and things tend to become a little bit less efficient. We know that our memory, attention, problem-solving abilities, processing speed are all vulnerable to age-related cognitive decline. I think it's kind of a sobering fact that from the time we're all in our mid-30s onward, we're on sort of a slow and gradual decline with our memory. But that's normal. We know that things like difficulties finding words in conversation, difficulties recalling names, misplacing items are all the types of cognitive changes that we might expect as our brain ages. Aging brains are also, though, vulnerable to neurodegenerative diseases, Alzheimer's disease being the most common. And I think, it can be difficult at early stages to differentiate between what is normal age-related decline versus what's pathological. And I think we're really fortunate at GW to have some pretty sophisticated tools for helping folks to differentiate that. And also, I think modifiable factors, things like depression, anxiety, problems with sleep, untreated sleep apnea, are all things that we know can affect brain function as we age, and we're able to help folks get a better picture of.
Yeah, very good. It's great to know there are interventions that are and evaluations that are useful. So, Dr. Puente, could you kind of expand on what we mean when we say a cognitive evaluation, and how does that fit into all this?
Well, great question. I think you might be thinking about the test that former President Trump took, and that's one of them. That's called the MoCA, and that's probably the most commonly used screener method that maybe you'll see used by our neurology colleagues or Dr. Prather in clinic. So a shorter test that can screen out for major problems, but maybe not be the most sensitive. And so the longer, more in-depth testing is called neuropsychological testing. And to Dr. Kelb, when she was describing the different components, for better or worse, you'll be with us for a few hours of your day. And it includes tests of memory, tests of attention, tests of problem solving, as well as how are you seeing and how quickly are you moving. So we try to cover all aspects of your thinking. And one thing we can do very well with our test batteries is we can help the patients and their family understand what is normal and what's not normal. How many times am I walking to that room looking for that thing and I can't find the word? And some of these things are just frankly and unfortunately very normal. And we can help guide them in that process. But it is a several-hour process in terms of the exam.
I guess I'm just hearing this. I'm wondering, what kind of feedback? How do you give feedback to your patients after these evaluations? How do you inform them and their caretakers or their family members or others?
Well, hopefully it's a team approach, right? And so if they come through the memory clinic with our esteemed Dr. Prather, Dr. Al-Chalabi, and feedback can start in multiple points. But with us, it's reviewing the test results at a very kind of 30,000-foot view. And if they want to get into the weeds, we can certainly do that. But helping them really diagnostically understand what is the condition that could be causing this, or is this just normal? And then regardless, what are things that they can do to treat this? So even if it's normal, it could be quite bothersome. And fortunately, as you've heard from all of our speakers, there's a lot of things within our own control without any formal prescription that we all can do. Really starting from midlife and onwards, even before that exercise and diet and social factors are very, very important.
Yeah, very good. But I guess those that actually do have needs for intervention often come to you, Dr. Prather, or further support. So I'm just curious, how do you, tell us a little bit about how you take care of patients or how you manage or support someone who does have an aging brain that's not as healthy as we'd like it to be.
Sure. So our memory clinic at GW with myself and Dr. Tanya Al-Chalabi lives in our geriatrics division right now. And what's really special about that, it's unique in DC and Northern Virginia and Maryland that it lives in geriatrics, because what we really know well as geriatricians, doctors who focus and have studied aging, is what is kind of typical and expected and what's not. And we're really trying to think about people in the mindset of age-friendly health systems, right? So mentation, how you think, how you feel, how your mind allows you to interact with the world around you, in your home and in your community. We think about medications a lot, right? A lot of us can take medications for years in our midlife that might actually cause dementia. Or we might be at risk of taking medications that worsen our cognition in late life. And so we think a lot about what we prescribe. We think a lot about mobility. If you don't use it, you lose it. And so we got to keep moving. And even when people start to have trouble with their cognition, we need to find ways to stay active and engaged in the community, because isolation and loss of autonomy are the things that we really, above all, need to avoid. And then lastly, really focusing on what matters to people. People say like, well, I love cruising. And I'm like, that's great. Better you than me, but you can still cruise with Alzheimer's disease, right? And how do we work with your family to make that happen safely? Someone might come to me and say, I don't have children in the area and I'm aging alone. And so we might say, okay, while we're doing everything we can to slow this process and make you function better, what do we need to do to plan forward in the future? And those are hard conversations, but often people are thinking about them. And so we can have them and have them honestly and in a way that really supports dignified, graceful aging with or without cognitive loss. And that's what we really try to do.
Yeah, that's wonderful. It's fortunate to have that degree of support and an engaged team around that. Let's switch a little bit to how we advance our understanding of our opportunities for intervention or for understanding science by virtue of clinical trials. And obviously, as an academic medical center, a really important part of our business, in addition to training the next generation and taking care of patients, is to really advance the care or the understanding of the mechanisms behind our diseases. So and we have several notable clinical trialists up here. I'm going to look to you, Dr. Kaminsky, first to speak about neurology clinical trials, and then talk to us about, but we'll talk a little bit later about why.
Absolutely. Before I get into that, I'd like to respond to something. I am definitely smarter than I was at 30. And my wife would attest to that. So, I'm going to be one. She's helped me along with that.
Wiser. Yeah.
So in terms of, I think what's great about coming to an academic medical center is that each one of us are really trying to think about how to advance the field. And so you have the opportunity to work with a physician who's thinking about the next steps to treat that patient. And so there's formal ways we do it. We have an NIH study where it's called a natural history study, where we have patients coming back to see us with very regimented evaluations and blood testing. Across our group, we have 370 patients now enrolled in that study. And so that gives us, and we've almost completed that gives us a really wonderful data set to really understand the disease that I'm studying. And then to be able to come up with a hypothesis and test it, which then will advance the field. I mean, my postdoc, along with my colleague's postdoc, Dr. Kushner, has really defined 2 different diseases within myasthenia gravis. So the patients that have entered this study, they're told, we're not here to help you specifically, but they're all willing to try to help the next group of patients to have their disease treated better. And then when it comes to clinical trials, there's really a great opportunity in some of these to really help that individual patient. And that really came to the fore for me. When you do a clinical trial, you have a pretty good idea that you think this medication is going to work based on a lot of science and a review by hundreds of scientists and regulatory bodies. But I had a young lady who, basically she was homebound. Her goal was to get through work and then rest. That's kind of what this disease does to you. And she had failed a bunch of treatments. We put her into a clinical trial, and she comes back 2 weeks later for her follow-up visit, and she says, I am a lot better. 4 weeks later, she is going out with her friends, and there's no other treatment right now that we have that would have been allowable to do that. And now her participation, her taking the risk of taking a drug that had never been taken by another human being, led to an FDA-approved drug. You know, that's the perfect situation, but it repeats itself in all the things that we do. And whether it's a drug or not a drug, or a new way to evaluate a patient, that's profoundly impactful for society. And that's what, quite frankly, all of us at GW are wanting to do, and want to develop that, not only personalized medicine, that we can do a test and give a medication that we know is going to work, but also to look at the bigger picture, like everybody has been referring to, you know, how does the disease affect them, and really give personal care to each individual. And that's real personalized medication. And I know, working with my colleagues, that's the way we do things at GW. Not even just in neurology, but cardiology too, and dermatology, and you name it. So.
Vaccines for one as well.
Vaccines.
So
yes.
many different areas, though, of really deep clinical trials, cancer biology, cancer in particular as well. So, but I guess one thing, you know, you also often hear about hesitancy about wanting to participate in clinical trials for whatever, you know, basically out of fear, I think would be the most thing. There's that notion of the guinea pig thing. And could you just speak a little bit to that really important component of equipoise that kind of allows you ethically and to participate in this?
Oh, absolutely. I mean,
Foundational.
If you already know the answer, you can't study it in a clinical trial. That's unethical. Then you really need to have an unknown and a validation to go forward within a clinical trial. And you explain that to the patient, that we don't really understand this disease. We think this is the correct way to go about it, but we don't know. And this was really quite, you know, I participated in the leadership of what's called thymectomy. We crack the chest, the surgeon opens up the chest, takes out the thymus gland, and for 100 years, it was thought to improve this disease, myasthenia gravis. And we polled a group of scientists and physicians, and they said, half of them said, I don't know. 25%, absolutely it works. We're not participating in this trial. Another said, no way, it doesn't work. So that's perfect equipoise, and that's the perfect question to ask in the clinical trial. And then the patients were willing to be part of this, and we discovered that it works for 2/3, not all the patients, but now we're trying to understand which ones it works for and which ones it doesn't. And it's always shocking to me that so many patients want to participate. And you know, the study I described is fairly easy. You give some blood. There's only been one patient out of the 83 here at GW who said, no, I don't want to do it. And she had some pretty good reasons why. But many patients really want to be part of the way to develop new knowledge. They want to give back to us as physicians and healthcare providers something for the next generation. They're just, quite frankly, they're just showing appreciation, which is phenomenal to me.
It really is. It's a very generous, service that our patients provide to us, and have really created such incredible. When I think about the way we used to treat cancer when I started this business 45 years ago, and how we do it now, it's all because of clinical trials. 100% of our real advances have been based on those patients that willingly participated in our clinical trials to make those well-informed decisions. It's really, really wonderful work and very gratifying. But it doesn't always just apply to treating diseases, though. You have your program, Dr. Prather Guide. Could you tell us about that?
Sure. So we're really excited at GW. We learned last week, we were identified as one site for a new national Medicare novel pilot program for comprehensive dementia care. So taking decades of research, like Dr. Kaminsky's talking about, in what works with treating a particular disease or condition that's happened across the country. And now that data is being translated into changing health policy and payment structures for how to comprehensively take care of an individual and their family unit and caregivers for persons living with memory loss. And we often use that term in my field, persons living with memory loss, because it's not just the individual, right? It's everyone that touches them. And so we'll be starting to be a site. So GUIDE focuses on education of individuals, but also education, support, and respite for caregivers and care partners. And this is an 8-year pilot, and it's really going to transform how dementia care is delivered over the next decade.
Is part of the goal of that to keep patients in their home unit in a safer, better informed? What are the outcomes you might expect from this?
Yeah, and you've seen individuals who have memory loss and the challenges of being in a hospital environment, right? And that actually really informed how my professional practice focused so much on outpatient care for people living with dementia, was trying to help people stay out of the hospital, stay in their homes, stay out of nursing homes and assisted living and memory care. And so the ideas of having built-in respite that's paid for by Medicare, which will only be accessible to patients who are enrolled in centers like ours that participate in GUIDE, that with planned, intentional respite and education and support, that will be able to age better in the community when there is memory loss present.
Yeah, very. Let's hope, huh? And less costly alternative too, I presume.
That is a big bucket of worms.
Okay.
It is, right, because we rely so much on our payer partners for individuals who have Medicaid or who rely on insurers to help provide in-home supports for individuals who aren't able to fund that independently.
Yeah, very good.
It is tough.
So do most patients with dementia find their way to your care themselves, or are they usually brought by family members? How does this usually evolve in your practices? What do you see?
So for us, we see everybody. We see individuals who are in midlife who are worried. Maybe they've cared for an older member of their family and they want to know about prevention. We see individuals who come in themselves and are like, I don't feel like I'm functioning typically. Can you help me figure out what's wrong? And then we see individuals who are brought in who, because of their condition, be it Alzheimer's or another neurodegenerative condition, don't know that they have a problem, right? And that term agnosia is so hard for people who are living with them, and it's their partner who's trying to get them in the door. And often we'll get referring physicians or nurse practitioners or PAs in the community, or even other specialists within our practice who are saying, I've got someone I'm worried about, can you see them?
Yeah, very good. So I've got just a general question for Dr. Kaminsky, Dr. Kubasi, but obviously one of the areas we haven't talked a lot about was stroke, and we are a comprehensive stroke center here at GW. Can you tell us a little bit about the current approach to brain attacks these days, and how do we do that at GW?
Of course, this is a really an exciting phase because what we're doing today has changed the outcomes of stroke completely. So just for to give a very quick couple of words about stroke for those who are not familiar, stroke is multiple kinds. Sometimes the most common kind is when there is decreased blood flow to a specific brain area, and deprivation of the blood can lead to the death of the cells of that particular area. So stroke can manifest as any kind of symptom depending on which area of the brain is affected. It can be visual changes, facial drooping, weakness or numbness on one side of the body, among others, sometimes inability to speak. But strokes also can be bleeding in the brain, among others. What we're doing today is, if there is a clot in a blood vessel, or a blood vessel is narrowed and hardened, which is the risk factor for stroke, and it gets completely occluded, threatening a region of the brain of complete brain cell death, we can do mechanical thrombectomy. That means if the patient comes to the emergency room within a specific duration of the symptom onset, then the specialist at our center will be able to introduce a catheter through the blood vessels and go to that particular clot that has closed the blood vessel and remove it. And if you look at the MRI, when the patient arrives and the MRI the following day, it's extremely, beautiful, the change, because you will notice that there is a big area of the brain that was initially deprived, and now all the blood flow was restored, and So we can do also injection of certain blood thinners through the catheter. And sometimes if the patient presents also within a short period of time, we can deliver medications through the vein that can dissolve the blood clot. So all of this is, represents a revolution compared to the old days when the saying was, if somebody has a stroke, the symptoms are irreversible and so forth. In addition to that, we have the rehabilitation unit, which uses modern advances in restoring function for those individuals who have had the stroke. But also there is a lot of ongoing research about neuroprotective agents. The neuroprotective agents are specific agents that are given to prolong the life of the brain cells that are at risk of decreased blood flow and restore the function early on.
Mm-hmm. So just for everyone that's online and listening, what are those signs again that we want to look out for, and how quickly? What do we do? How quickly must we get to these interventions?
Yeah, thank you for this question. We always teach that time is brain. So you want to get to these interventions ASAP. The symptoms can be anything from sudden onset of visual loss, sudden onset of weakness on one side of the body, sudden onset of incoordination, inability to speak, or sometimes the patient is able to speak, but they're unable to understand language, depending again on which area of the brain is affected. Facial drooping, and the patient may not be aware of it, but family members or viewers witnesses will be able to see that there is asymmetry. So basically, any sudden onset, one fundamental feature of stroke is the acuteness of it, is how sudden the symptoms occur, because as soon as the blood clot stops the blood flow to a specific brain area, the symptoms emerge immediately. So within any such, when any such symptom occurs, immediate 911 and EMS should probably bring the patient to the closest emergency room where stroke care is delivered with the hope of reversing those things. Another area that has also improved outcomes in the country is telestroke. So there are a lot of centers, they have a physician who connects from remotely to give advice about what to do in a specific stroke regions. And Dr. Kaminsky and I have been trying to work with different areas within Washington to provide that service to hospitals that don't have comprehensive stroke care.
Yeah, very important, yeah. Very good. Well, I think, I bet you we have some questions from the audience, and I'm sure we have a very knowledgeable group here to answer them. Do we have anyone who'd like to ask a question about a neural, here we go, right here in this gentleman right here. And then right behind you, there's another gentleman I think I can see.
Thank you for a very interesting presentation. I am aware of the benefits of exercise, sleep, diet. There are a lot of pills on the market, some of them widely advertised, Prevagen and Nariva. CVS has two, a brain support and memory health, which if you look at the box, it's the same pill being marketed under two different names. I asked my pharmacist if he could recommend any of these, and the most substantive thing he could come up with is they seem to work for some people. Do you have anything more substantive you could say about these over-the-counter pills, or any that you would recommend? And Dr. Zielinski, is there anything FDA approved that is available over the counter for memory support?
Well, I'm going to punt that to our memory experts over there.
I think you're right that they might work for some people. At the end of the day, we want good, nutritious input, right? And if someone has deficits in their nutrition or what they're able to eat or what their body's even able to absorb because of another health condition or a medication that's been prescribed, those supplements might in fact make them feel better and think better. But at the end of the day, we don't have great evidence that it changes what's happening in the body.
These things, systematically for clinical results?
There's a lot of ongoing research into a lot of these different things. But I think you might be hard pressed to find someone to say that one of these over-the-counter agents is better than another. And there's certainly a lot when we look to our traditional medicine and different cultures, whether it's Chinese herbology or the Ayurvedic traditions, where there's long-standing tradition that different herbs and plants are helpful in medicine. And we know that from penicillin, we know that from, so many of our drugs come from the land. And so we are in a place where that's still, I think, being explored in the mind space. Even the FDA-approved medication for early memory loss, donepezil, of which there's many cousins and agents, that all derives from an original plant herb that came from the ground, which was huperzine. So we can always look and try to find data.
What was the one you mentioned just now?
Huperzine?
You just spell that?
Huperzine. Just to clarify, not endorsing, just to point and say, we have to be open-minded about where we get our medications
Can
from.
you give me that spelling again?
I'll find you, can I find you after?
Okay.
Okay.
That's very good. Okay.
I can add one point too. I think invest your money in your diet. And so that's a rule of thumb. And supplementation, there's really no evidence that supplementation goes beyond once you're hitting normal levels, that there's a benefit to your memory. So, and the Prevagen studies are very weak on their memory outcomes.
If there are concerns about memory, your clinician will do the blood work that is relevant. The blood work includes looking for vitamin B12 levels and other things, your thyroid function. If there's any deficit in any of these, then supplementation, like Dr. Prather said, will be important. Otherwise, most likely what people describe as benefit from unnecessary over-the-counter supplement is probably placebo.
I am going to say, however, that as a surgeon, even though I don't treat hypertension and diabetes and things like that, we also want to make sure that your regular health maintenance to achieve goals relative to hypertension, renal function, diabetes, all those, no shortcuts. Yeah, I'm sorry to say. Next, yes.
I thank you, Dean Bass, for hosting, and to our wonderful colleagues for a great talk. I just want to shout out to my two colleagues there, Dr. Puente and Dr. Kill from the Department of Psychiatry. Question, given the complexity of brain health, how do individuals navigate the abundance of the advice out there, the information out there, in making that informed decision about maintaining their cognitive well-being?
Well, hopefully they'll come to us and ask us these questions. But yeah, I think it starts with a team of people, and I do think there's just an overwhelming amount of stuff out there. And take diet. Maybe some of you are going to go home and Google diet memory. You're going to get a lot of hits, right? But in terms of evidence, we can hopefully steer you in the right direction in finding very specific things that you can sink your teeth in and invest your time in, rather than get caught in the different rabbit holes of the internet.
Now, I'll add to that I think, again, I don't practice as a primary care physician. I think there has been a shift over this last 10, 15 years or so where physicians really do consider whole health in a more comprehensive, integrative way than we did for years. We used to be very problem-focused, and would treat this and treat that. But there really has been, if you find a good primary care physician, like you will at our place, really that takes that whole health approach and really does integrate into your care, into your lifespan, these other elements of wellness that often don't come with a pill, which is what we really hope to do, keep as few people on pills as possible.
Thank you for your comments. The DMV is very demographically diverse, as opposed to some areas like rural Minnesota or Utah or South Dakota. So to what extent in your various clinical trials are the various demographic groups represented, and what kind of differences have you seen? For example, there's anecdotal data that Alzheimer's affects women more and people of color. So could you make a few comments about demographic variables?
So I can take that one. So you are 100% correct that we have to have conversations about race and gender and culture and our genetics and all the things that make us who we are when we talk about these conditions. And our group actually partnered with DC Health back in 2020 to do exactly what you just talked about, which was to look across the entire District of Columbia and say, who is living with dementia in our community? And what we found was staggering, right? So nationally, Alzheimer's numbers, range 8, 9, 10%, depending on the population you look at. And here in our wards 2 and 3, lower. Wards 5, 7, 8, and 9, in some places up to 18, 19% incidence of dementia in persons of color. And so what we have to do is take that data and reach out to our communities and work closely on education, prevention, reducing stigma, changing what the individuals who work in our field look like, right? So that we can have race and culturally concordant care. Maybe someone wants a dementia provider who doesn't look like me. Maybe they want a dementia provider who looks like them. And so our research institute, the Brain Health Research Institute, is actually launching this summer an inaugural Brain Health Month with DC Health, focused entirely on community education and screening to bring this knowledge to people who are living with it, to help break down that stigma and barrier about asking for help. Because patients are the best when it comes to empowering their own health.
If I could just add to that as well, when we did the vaccine trials back in the early days of the pandemic, Dr. David Diemert led our trials here. And as it turned out, our site at GW was the most diverse, had the largest number of underrepresented minorities in medicine participate in our trials. We were very proud of that. Over 50% of our participants were people of color, which was unusual, I will say, for the vaccine trials. We really are intentional about that. The other thing is that I want to just, since we're talking about this, we are getting ready next March to be opening a new hospital east of the river, as you may all know, the Cedar Hill Regional Medical Center, which will be an academic community hospital that we at GW are very proud to be providing the physician, advanced practice provider staffing for. We are also going to launch there a family medicine residency program and a new department of medicine to really provide a new access to the full spectrum of healthcare, from sophisticated primary care in the form of family medicine, really one of those wonderfully holistic models, all the way through the specialty access that we have in a real integrated network with our current program for specialty care. So we're excited about that. Yes?
Yeah, so we do have a few questions in the chat online. A couple of people have asked the panel to speak about THC, and if there's anything that you all can say about the impact on brain health and what we know now.
Okay, any takers?
I can speak a little bit to that. I think...
And maybe repeat the question in case everyone didn't hear it.
Yeah, the question was about the impact of THC on cognition, and I think that we still have a lot to learn in that area. We kind of live in a new time where the use of that is increased so much. I think the research hasn't quite caught up yet. I don't think we have super strong data about any long-term neurologic impacts, but certainly short-term use can impact things like our short-term memory, our processing speed, our attention, and so it's not without potential disadvantages. So.
Okay. One more? I think we're almost out of time. Do we have one more?
Yes, we do. One of the folks online wanted to ask about the long-term impact of stroke, and if there's anything that the panel can speak to about, interventions years after the event and their effectiveness.
Yeah, I can take that. So if stroke occurs at an relatively early age, the chances of recovery become a lot better, simply because of what I mentioned about neuroplasticity, which is maximum during childhood, and then it gets less and less as we age, but it doesn't stop. So any brain at any age is capable of learning new things, but sometimes not capable of complete healing from injury. If you go to the scientific meetings these days, you will see a plethora of new devices and machines that facilitate recovery from motor deficits in stroke by playing games and by assessing the strength of the limb as it moves, and by giving something like a mouse to follow something on the screen. All of these sort of like game-like stuff have been shown to improve mobility and improve motor activity after stroke. What we learned in medical school, we continue to teach now, namely, the motor recovery of stroke is best in the beginning, but it continues to happen until at least 1 year after the onset of the stroke. Beyond that 1 year, the improvement becomes less conspicuous. However, with the recent advances, it is likely that this is going to be expanded as well.
Very good. Well, I think our time is up. I want to thank you all for spending an hour with us. I want to thank you for your attention as well, and great questions, and look forward to seeing you.
Thank you.
Thank you.